Hello and welcome to the second part of the Hematology series, Coagulopathies. The objectives for this lecture are as follows. Develop an understanding of the relevant anatomy and physiology of the coagulation cascade in platelets. Compare and contrast the various forms of coagulopathy. Understand the management principles of coagulopathies through the use of pharmacologic and non-pharmacologic methods. Describe the mechanism of action, contraindications, side effects, and implementation of anticoagulant therapies. Let's begin by looking at platelets. Here is an image reminding you that platelets are derivatives of the myelogenous line and come from megakaryocytes. Some of the catalysts for differentiation into a megakaryocyte include stem cell factor, thrombopoietin, interleukin-3, and granulocyte monocyte colony stimulating factor. The normal range for platelets is 150 to 400,000. Platelets are essential to blood clotting. Whenever platelets are low, there's an increased risk of bleeding, especially under 50,000. Whenever platelets are high in concentration, especially greater than 1 million, there's an increased risk of clotting. Secondary thrombocytosis is a condition where there's excessive platelets, often greater than 400,000. This is often reactive and caused by infection, chronic inflammatory disease, iron deficiency, malignancy, acute hemorrhage, and splenectomy. It's manifested by increased risk for clots and coagulation. In terms of diagnosis, the platelets are elevated, and there's usually evidence of the underlying cause. In managing this condition, it's important to target the underlying cause, and it usually returns to normal once it's corrected. The opposite problem occurs with thrombocytopenia, when the platelets are less than 150,000. The causes of thrombocytopenia are broken down into three groups. Decreased platelet production, which occurs with malignancy or metastasis, aplastic anemia, toxins, certain medications, chronic alcohol consumption, liver disease, infection, or chemo and radiation. The second group is increased destruction, which can come from antibodies, which you would see with idiopathic thrombocytopenia purpura, systemic lupus erythematosus, or certain medications, or infection such as sepsis or post-viral syndromes. The third group is increased consumption, which can occur with disseminated intravascular coagulopathy, major bleeds, pulmonary emboli, and devices, such as an intra-aortic balloon pump. Thrombocytopenia is manifested by bleeding and petechiae. It's diagnosed by CBC, a bone marrow biopsy, and diagnostics related to the suspected underlying cause. The management includes targeting the underlying cause, platelet transfusion, or splenectomy. While we're discussing platelets, let's take a moment to discuss antiplatelet agents. These drugs decrease the formation of platelet plugs by decreasing the responsiveness of the platelets to stimuli that would cause them to stick and aggregate on a vessel wall. Side effects of these medications include bleeding, bruising, headache, dizziness, weakness, nausea, and vomiting. They're contraindicated in allergies, bleeding disorders, recent surgery, closed head injury, pregnancy, lactation, and thrombocytopenia. The following are some considerations for the patient with thrombocytopenia or the patient on an antiplatelet agent. Encourage the consumption of small, frequent meals to decrease GI upset. Implement safety measures such as the use of an electric razor and avoidance of contact sports. Monitor platelets. Implement precautions against bleeding such as pressure dressings and ice. And educate. Now let's take a look at the coagulation cascade. Here is an image showing the coagulation cascade. The intrinsic pathway is initiated by damage to the endothelium. The extrinsic pathway is initiated by trauma. These two pathways converge into the common pathway and ultimately lead to the development of a fibrin clot. These highlighted factors are produced by the liver. I included this slide as a reminder that liver disease can result in a bleeding disorder. If you refer back to the hepatic disease lecture, you will notice that acute liver disease will prolong the PT. Alteration of these factors are the cause of the prolonged PT. Coincidentally, warfarin works on these same factors produced by the liver in addition to factor IX. These factors are dependent on vitamin K. The prothrombin time is used to evaluate the extrinsic system and the common pathway in the clotting mechanism. It measures factors 1, 2, 5, 7, and 10. When these clotting factors are deficient, the PT will be prolonged. The INR is a uniform version of the PT. I've included a table with indications and the preferred INR. Here's a little more information on warfarin. There are a variety of drugs that interfere with warfarin's action, but I especially want you to know the foods that interfere with warfarin action. Here I've shown the targets of some of the other anticoagulants. Apixaban, or Eliquis, and rivaroxaban, or Xarelto, target activated factor 10. Dabigatran, or Pradaxa, targets thrombin or activated factor 2. Heparin, on the other hand, interferes with the conversion of prothrombin to thrombin, the conversion of fibrinogen to fibrin, and the final step of the conversion of fibrin to a cross-linked fibrin clot. The partial thromboplastin time, or PTT, is used to assess the intrinsic system and the common pathway. It's especially used to evaluate heparin. Here's an image showing the clotting factors that PTT evaluates. Fibrinolysis is a second cascade involved in clot dissolution. Plasminogen is converted to plasmin under the influence of activated factor 11 or 12, antidiuretic hormone, epinephrine, pyrogens, emotional stress, and physical activity. This stimulates the dissolution of clots. Thrombolytics act by stimulating the conversion of plasminogen to plasmin. Thrombolytics function in breaking down a thrombus that has been formed by stimulating the plasmin system. They're contraindicated in recent surgery, cerebrovascular accident, active bleeding, aneurysms, gastrointestinal bleeding, recent trauma, a known coagulopathy, uncontrolled hypertension, and liver disease. Now let's discuss some of the coagulopathies. Idiopathic thrombocytopenia purpura, or ITP, is the autoimmune destruction of platelets by antiplatelet antibodies, resulting in three characteristic signs: petechiae, purpura, and excessive bleeding. This condition often develops 1 to 4 weeks after a viral infection and is most common in young children. It's diagnosed by a platelet count that's less than 50,000, a normal H&H unless there's a hemorrhage, and normal white blood cells. In ITP, when the platelets drop below 20,000, corticosteroids and IVIG are administered. Platelet transfusions are usually held unless there's a life-threatening situation, such as intracranial hemorrhage. If ITP persists for greater than 1 year, a splenectomy is considered. It's important to avoid NSAIDs, aspirin, and antihistamines due to the risk of anemia. Instead, acetaminophen can be used for pain control. Also in these patients, it's important to encourage them to avoid strenuous or rough activities. and encourage an alternative such as swimming. Disseminated intravascular coagulopathy, or DIC, is a battle between coagulation and anticoagulation. It's triggered by septic shock, endotoxins, viri, tissue necrosis or injury, and cancer treatment. Hemorrhage and organ tissue damage results if it's not identified readily. In DIC, manifestations of anticoagulation includes petechiae, purpura, hematuria, hematochezia, and oozing from venipuncture sites or the umbilical cord. Manifestations of coagulation includes decreased oxygenation, circulatory collapse, and decreased urinary output. Laboratory findings include decreased platelets, an increased PT or PTT, decreased fibrinogen, and an increase in fibrin split products or D-dimer. The management of DIC involves targeting the underlying cause, for instance, antibiotics for underlying infection. It's important to stop all anticoagulation. The use of heparin has been controversial. It's thought to counteract the deficiency in the coagulation-anticoagulation pathway, and it's also been shown to reduce the consumption of platelets. You may also apply pressure, cold compresses, or elevate extremities whenever there's a bleed. These patients may require clotting factors, platelets, and cryoprecipitate to prevent hemorrhage. Hemophilia is an X-linked recessive disorder resulting in deficiency in one of the coagulation factors. It's diagnosed by a decreased H&H and decreased factor levels. This condition is manifested by intracranial hemorrhage, prolonged nosebleeds, easy bruising, and warm, painful, or swollen joints with decreased range of motion. You may also see GI hemorrhage. There's no known cure for hemophilia. It's important to avoid injury and medications that promote bleeding, encourage good nutrition and dental hygiene, and these patients may need IV administration of deficient clotting factors. Von Willebrand disease is a condition of deficient or ineffective von Willebrand factor. This factor acts as a carrier protein for factor VIII in the plasma. It also helps with platelet aggregation and adhesion to damaged endothelium. This condition is manifested by epistaxis, easy bruising, bleeding after oral surgery, or menorrhagia. The management is similar to hemophilia. It's important to prevent injury or bleeding, and these patients may require administration of von Willebrand factor if there's a bleed or injury. This is done through the administration of cryoprecipitate. These patients may also benefit from desmopressin or DDAVP. This medication raises the plasma level of von Willebrand factor from the stores in the endothelium of the blood vessels. This results in the release of factor VIII and von Willebrand factor from these stores. This may be done prior to surgery or dental work. Hyperhomocysteinemia is a condition resulting from abnormal vitamin B12 and folate metabolism. The image here reveals the relationship between these vitamins and homocysteine. Homocysteine is normally converted to the protein cysteine under the influence of vitamin B6. Homocysteine promotes platelet aggregation, resulting in an increased risk for DVT, pulmonary embolism, ischemic cerebrovascular accident, and acute coronary syndrome. It can be diagnosed by a fasting homocysteine level or a methionine challenge drawn 4 hours after consumption of methionine. Management includes anticoagulants and smoking cessation. At this time, there's no support for the use of folic acid, B6, and B12 supplementation. Antithrombin is a protein that normally inhibits thrombin and certain coagulation factors. It also diminishes inflammation of the endothelium of blood vessels. In patients who are antithrombin deficient, they're often heparin resistant, requiring large doses of heparin. Next, let's discuss diseases of protein C and S. Protein C is a vitamin K-dependent enzyme synthesized by the liver. It inhibits coagulation when it's activated. In protein C deficiency, there's an increased risk of thrombosis. These patients are also at risk for warfarin-induced skin necrosis. When this occurs, it's important to stop the warfarin, administer vitamin K, heparin, fresh frozen plasma, and/or purified protein C concentrate. Protein S is a natural anticoagulant produced by the liver. Activated protein C requires protein S to inactivate certain coagulation factors. Deficiency results in a diminished inactivation process, resulting in an increased risk for thrombosis. This condition is associated with pregnancy, DIC, liver disease, nephritic syndrome, and HIV. The factor V Leiden mutation synergistically increases the risk of thrombosis in patients with other risk factors, such as the use of oral contraceptive pills, hyperhomocysteinemia, or increased age. In these patients, there's a very high risk of thrombosis, often an 80-fold increased risk. Management includes anticoagulations for months following an event or anticoagulation for life. Antiphospholipid Syndrome, or APS, is the association of antiphospholipid antibodies with a variety of clinical features characterized by thrombosis. Persistently elevated antiphospholipid antibodies to various phospholipid-binding plasma proteins results in the development of microvascular thrombosis. Risk factors for this condition includes a history of systemic lupus erythematosus, autoimmune rheumatologic disorders, or other autoimmune disorders. It's manifested primarily by thrombosis, but you may also see a history of pregnancy loss or signs and symptoms of autoimmune disease. In terms of the diagnosis of antiphospholipid syndrome, these patients will have a positive lupus anticoagulant. They'll be positive for anticardioliptin antibodies, anti-beta-2 glycoprotein 1 antibodies, and they may have a positive antinuclear antibody if they have a history of systemic lupus erythematosus. Management includes the use of unfractionated or low molecular weight heparin, steroids, and IVIG.